Welcome to the second part of Granville County EMS CME for March of 2020. The first part of CME was the coronavirus lecture. If you have not watched that, please stop watching this and watch that first because that's absolutely more important and more timely. Once you've done that, go ahead and feel free to continue with what we had originally scheduled for CME, which is chest pain. So we're going to discuss chest pain, what we should be doing for our patients, what best practices are, recent changes in research and protocol. So when we talk about medical chest pain, we usually talk about the big six or the chest pain six-pack. You know, whenever I have a patient come into the emergency department, I think of them as having 6 possible causes for their chest pain that could kill them. Of course, there are other causes of chest pain, but these are the ones that I can't miss and that I would argue we need to be thinking about pre-hospital as well. So ACS, acute coronary syndrome. This includes everything from angina to NSTEMI to STEMI. Second, PE, pulmonary embolism. Third, pneumothorax. Fourth, aortic dissection. Fifth is some type of esophageal tear, puncture, or injury. And the last is cardiac tamponade. And I've listed those in terms of their likelihood as well. So, ACS, PE being much more common, esophageal tears, cardiac tamponade being much less common. So first I'm going to talk about non-cardiac chest pain, non-ACS causes. And then we're going to spend the last half of the talk focusing specifically on ACS. So what are these other causes? Well, pulmonary embolism. I would argue that this is probably the second most common one, statistically speaking, and you should always be thinking about when you have a patient with chest pain. Signs and symptoms, shortness of breath, but not always. Hypoxia, but not always, unless the PE is quite large. The actual most common exam finding for someone with pulmonary embolism is unexplained tachycardia. Risk factors include recent surgery or birth. In fact, this picture you see right here these are pulmonary embolisms, obviously massive branching embolisms that were removed from a patient immediately following a C-section. Something about the birthing process and the hormonal fluctuation that occurs around birth puts patients at high risk for PE, and that risk seems to last for about 4 to 6 weeks out postpartum. So if you have a patient with a recent C-section or recent natural vaginal birth who maybe is short of breath, has an unexplained tachycardia, PE should be in your mind. Recent travel, and people always wonder, well, how far? It seems that about 4 hours of immobilization, so car ride or plane travel, seems to be the cutoff. Obesity is actually alters your hormones, and we think that's why obesity is related to pulmonary embolism. Obesity basically sort of mimics high estrogen states, and so it's very similar to being on hormone therapy, which is another risk factor, birth control. And probably the biggest risk factor by far is prior PE. Now, in the pre-hospital setting, it really comes down to having a high index of suspicion. We do talk a little bit about the S1Q3T3. You'll hear people talk about this a lot in regards to PE, that this idea of patients with a PE will have a deep S wave in lead 1, they'll have a deep Q wave in lead 3, and they'll have inverted T waves in lead 3. And there's a couple older papers that suggest that this has a high correlation with PE. In reality, it's not that accurate. So only about 10 to 50% of patients with PE will have an S1Q3T3 pattern. Depends on the study. Some studies say as low as 10. You also often see S1Q3T3 in patients without PE or anything wrong with them. Again, the most common EKG change you're going to see is just tachycardia, above 90 to 100 in an otherwise healthy person, and you can't really explain it. Like that may be your only indicator of PE. So if you suspect PE, we still want you to do the standard chest pain bundle that we're going to talk about for the last half of this lecture. One thing you may want to be careful about is not giving nitro, because if someone has a large PE and you drop their preload, you drop venous return to the heart, that can cause hypotension. If you are going to give nitro, at least have an IV in place. And people with PE tend to do better with fluids. So if you suspect PE, you can go ahead and give 500 cc's, fluids wide open. It's not going to cause any harm. But basically for these patients, it's more about suspicion, supportive care, letting the ER know your concerns. So pneumothorax, this is one that we do not want to miss in the pre-hospital setting because it's one that we have a specific intervention for. So symptoms of pneumothorax: shortness of breath, obviously diminished or absent breath sounds on one side. JVD, but that's a late finding. By that time, you're having a pretty severe tension pneumo. Same thing with tracheal deviation, also a late sign. And keep in mind, pneumothoraces tend to be atraumatic. Most of the ones that I have seen at Granville tend to be people who just coughed and, maybe they have COPD and they have blebs and they popped one. When young people get spontaneous pneumos, they're usually tall, thin people. There seems to also be a high association with vaping. So if you have a pneumothorax and it meets criteria for a tension pneumothorax as per protocol, I just want to briefly review the needle decompression. So basically, you're inserting the needle into the skin just over the top of the third rib. The reason you want to be close to the top of the rib and not close to the bottom of the rib above it is because most of the blood vessels run along the bottom of our ribs, kind of right behind that bony edge. So that's why we focus on staying towards the top of the rib below that space. Mid-clavicular line is generally what we do in EMS, and you're inserting that needle in that catheter until you hear a rush of air, and then sliding the catheter in further. So, third cause of chest pain that's not ACS, aortic dissection. So, to be honest, I've probably only seen this 2-3 times with certainty, and patients always look the same. They are writhing in pain. You cannot keep them still on the bed or the gurney, and they will tell you, I feel like I'm being torn in half. I feel like someone is tearing my chest. The pain tends to be very uniquely different from what most people with cardiac chest pain complain about. The most common radiation that's specific for dissection is radiating to the back. People will often say they feel it between their shoulder blades. And then there's this idea of unequal blood pressure. We always talk about if you suspect dissection, check blood pressures in both arms, and if they differ by more than 10 to 20, that should raise your suspicion. The truth is that has not held up very well in studies. About half the US population has a difference of more than 10 between arms, and about 20% of the population has a difference of greater than 20, and they don't have dissections. So, feel free, if you have the time to check pressures in both arms, don't prioritize it. And, just because it's not that different in both arms doesn't necessarily mean that they don't have a dissection. So dissection treatment, again, standard chest pain bundle. But I would say 2 things. One, if you really suspect a dissection, call med control and discuss withholding aspirin. I mean, obviously, if someone has a dissection and they're very prone to bleeding, aspirin is not going to be beneficial in that circumstance. And also, you want to contact med control for possible diversion, because it is, although we can evaluate for dissection at Granville, by the time we do that and get them back on an ambulance and divert them, that's a very considerable amount of time for someone who has an immediate surgical emergency. So if it's a really good story, the patient's age and what they're describing really fits, and we think it's high on the differential, we will likely divert you to Duke. So esophageal tear, pretty uncommon, but is a cause of chest pain, and one that we really don't want to miss because it has a high mortality. Again, it's often severe chest pain and usually occurs with retching or vomiting. We see this a lot in chronic alcoholics. Other things that can damage the esophagus, like certain types of chemical ingestion, like bleach and other caustic substances, can cause esophageal tears or punctures. An esophageal cancer, a tumor that has grown through the wall of the esophagus, can do it. And foreign bodies can poke through. And this picture here, what you're seeing is that tube that's kind of running down to that white ball, the sort of tube filled with white to the white ball there on the right. That's the esophagus going to the stomach. But inside that circle, you can see contrast dye spilling out. And there should not be any contrast dye there. And so that's how we actually identify this in the emergency department. So treatment, again, these are pretty rare. I would always assume that this is probably not what's going on. Generally, if you do the standard chest pain bundle, that is going to be sufficient care for these patients. And again, if you have a really high index of suspicion, especially if someone has drunk a caustic substance or it's a good story for a foreign body, call med control because we may divert in that case. And the last cause I want to mention, although probably the most rare of everything we've talked about, is cardiac tamponade. This can be spontaneous, but it is usually traumatic, so you're usually going to suspect it. When it's not traumatic, it's usually from pericarditis or a chronic rheumatologic condition, something causing chronic inflammation. Sometimes this can happen if someone's had a recent cardiac procedure, although most cardiac procedures, they cut the pericardial sac, for example, any type of open chest surgery, they cut the pericardial sac, so you're not going to get tamponade. But some of the less invasive intravascular procedures could cause a perforation, could cause the pericardial sac to have a slow bleed into it. But again, most commonly you're going to see these with trauma. So if you think you've got cardiac tamponade, again, similar to PE, similar to right-sided MI, this is a situation that nitro may not be the best option. Again, if you drop preload, that can cause blood pressure to drop precipitously. So you always want an IV in place. If you are going to give nitro, you want fluids ready. And this is also a situation where you might want to avoid aspirin because, again, it's usually bleeding into the pericardial sac, although sometimes it can be more of just like inflammatory fluid. Again, if you have a strong suspicion, I would contact med control for further direction. So the takeaway, I always want to, we always talk about chest pain is chest pain is chest pain, meaning always assume chest pain is ACS, always treat people as if they have true cardiac chest pain. And again, statistically speaking, that's the right thing to do. But we do know there are these 5 causes I just mentioned that are life-threatening and are treated differently. So, I've reviewed them just to keep them fresh in our mind. And what I'd like you to do is if you really think you have one of them, contact med control, discuss any potentially contraindicated medications because there are a few. But otherwise, you're still going to be doing supportive care, chest pain bundle, and then going to wherever medical control tells you to go. So back to cardiac chest pain. So we're going to talk about the chest pain bundle. And, you hear that word a lot, bundle, chest pain bundle, sepsis bundle, trauma bundle. All a bundle is a group of interventions that we want to do for every patient every time when they meet a certain criteria. And to be honest, most of your protocols are bundles. They're combinations of best practices. Someone's got COPD or asthma, there's a bundle there. It's steroids, it's nebulizers. And you have learned a chest pain bundle. The one that we all learned in paramedic school is MONA, right? Morphine, oxygen, nitrates, and aspirin. And this has been the classic teaching for years and is still taught not just in EMS, but taught to every medical student, taught to every intern. The problem with MONA is that MONA is a little antiquated. MONA kind of came into existence before we had a lot of the other substances and medications that we use for treating chest pain. And it's really time that we sort of update our thinking. And so what I'd like to try to get you to do is, instead of thinking MONA, to think thanks mom. And it's a little more complex, but Thanks Mom really represents best practices for chest pain. And so whenever I have a patient with chest pain in the emergency department, I basically run a version of this in my mind. So 2 words, Thanks Mom. Each one of those letters stands for what you see on the screen, and we're going to go through them one by one. So the first one, T, stands for 12 lead. In the ER, we also say it stands for thrombolytic because we have to decide, if we're going to do that. In EMS, 12 lead, right? 12 lead is what really allows you to make the big decision. Are we going to Granville? Or are we going to Duke, Durham Regional? And we know that 12 leads by EMS make a huge difference in outcome. So just by doing a 12 lead, you increase the odds of that person getting to intervention. And by that, we usually mean cath, to the cath lab. You increase the odds of them getting to the cath lab in under 90 minutes by 33%. That's a big difference. And we know that just doing 12 leads in the pre-hospital setting reduces overall death by 12%. And you got to wonder, well, why is that? Because, the 12 lead doesn't actually do anything to the heart, right? It doesn't reduce the clot. It's not a thrombolytic. But, when you choose not to do a 12 lead, and you show up at an emergency department with chest pain, but you haven't done a 12 lead, that prompts the receiving nurse, the triage nurse, and everyone else who sees the patient to take the call a little bit less seriously. We don't realize this, but in EMS, when we start going down a route, like an idea, we decide, okay, I think this patient has real chest pain, or I think this patient doesn't have real chest pain, or I think this patient has a pneumo, whatever it is we think is going on, we start treating the patient that way. And then the receiving facility expects to receive a patient with that problem. And so everyone's mind is biased towards whatever it is we've decided in the pre-hospital setting is happening. And so just by raising your awareness and having a low threshold to treat chest pain as real and do 12 leads, that's going to prompt the receiving ER to also treat the patient seriously and look for cardiac causes of chest pain. And so this has been shown in multiple studies. Just doing the 12 lead by EMS decreases overall death by over 10%. So that's a huge difference you make with an intervention that's easy to do, non-invasive, and I would argue every patient, every male over 35, every female over 40 should be getting. So we're going to do a bunch of 12 lead towards the end of this talk, but just a couple pearls. Even if the 12 lead is normal, please repeat it in 15 minutes if your transport is long enough to do that. Left bundles. So we used to talk a lot about left bundles. When I was a resident, kind of 2008, 2010, we would divert every left bundle to a cath lab in New York City where I was training. And the idea was that unless the patient knew that they had a left bundle, we assumed it was new, and we assumed it was the equivalent of a STEMI. So the research hasn't really supported that. We actually did a study in New York City where we looked at every left bundle that went to a cath lab. And what we found is that you would have to, for every 1,000 left bundles that were diverted to the cath lab, only 2 of those patients ultimately benefited from intervention. So it's 1 out of 500. So basically you're diverting a huge number of patients and activating the cath lab a huge number of times for relatively low benefits. So we no longer divert patients solely on the presence of a left bundle. And the other thing I'll say is, who gets a 12 lead? And this is always something that's debated. So if you're over 35, especially if you're a male, if you're over 40 as a female, and you have anything resembling chest pain or its equivalent, you deserve a 12 lead. And the one thing I will say to the crews out there that have a medic and a basic or a medic intermediate is that, if you do a 12 lead on scene, if you think someone meets that criteria and you do a 12 lead and the 12 lead's reassuring, that is not enough to let the basic or the intermediate tech the call. Once you've decided the patient deserves a 12 lead, that's an ALS call, which means the ALS provider needs to be in the back with the patient. So who gets 12 lead? We talked about, males over 35, females over 40 who have any of these things. So obviously chest pain, and it doesn't matter if it's typical or atypical. Epigastric pain, we know a lot of chest pain actually people interpret as being stomach pain. Any pain to the back, neck, or jaw without chest pain that you can't otherwise explain. Someone with palpitations, even if they're not having palpitations right now. Any of your syncope or near syncopes. Obviously anyone in pulmonary edema, but of course treat the edema first. Exertional dyspnea that's new. Weakness that you can't explain. Diaphoresis that's not related to temperature, or someone who's just, having that panic attack, that anxiety, that impending sense of doom. Most of the time it really will be just a panic attack, but, you do this long enough, and I've seen this, and I think many of you have, people having the big one will sometimes, for all intents and purposes, look like they're having a panic attack. The other thing that's worth doing a 12 lead is anyone who's hyperglycemic, DKA or just hyperglycemia without DKA. And the reason for this is there has to be a reason that their blood sugar is elevated. And actually, one of the causes of unexplained elevated blood sugar is an infarct. So we do see hyperglycemia with cardiac events. And in fact, that's before troponins were invented. That's one of the things you would look for was high blood sugar. And so, especially if their high blood sugar is not explained, it's worth doing a 12 lead. So that's T, 12 lead. So the next letter, H, heparin. Now, I realize in North Carolina, we don't give heparin pre-hospital. They do in some other places. And, I always like to train paramedics as if they could work anywhere. So even though this may not be done here, it's done in other places. And so you should know about heparin. Also, and this is really the reason that I want to cover heparin, is we do interfacility transports. You guys run the bulk of the patients who need to go to Rex for cath or Duke for emergent STEMI cath. You are the ones doing the transports. And so your patients will have heparin, or at least should have heparin. And that's one reason I want to talk about this. So what does heparin do? Well, heparin interferes with what's known as the intrinsic clotting system. It actually interferes with a lot of steps of the clotting system, but ultimately, when you look at this diagram, what we care about is the fact that it interferes with thrombin. And that's what prevents fibrin from forming. Fibrin is that sort of meshy network that platelets really stick to that really creates a clot. So when you give heparin, although you're not busting clots, what you're hopefully doing is preventing clots from becoming any larger. And heparin is really the standard of care. And every single patient going to Rex or Duke for cardiac reasons probably should have heparin hanging. So what I'd like to ask you all to do is, if you are doing an interfacility transfer and the patient does not have heparin hanging, please ask why, because we have actually had more than a few cases where patients were supposed to be transferred on heparin and they weren't. And that happens for a few reasons. One is sometimes things are moving so quickly, like in a STEMI, that the nurse just doesn't get enough time to hold it or to hang it before you're taking the patient out of the door and it gets forgotten. Another thing that happens is patients will sometimes go for imaging, and so the IV will be disconnected and then it never gets reconnected before the transfer. So if you're transferring someone for STEMI or NSTEMI, someone with a positive troponin, and they don't have heparin, please ask. And there's going to be three reasons or three responses that the nurse should give you. One is there are situations where we only give the bolus and then send the patient. So the nurse could say, well, we gave the bolus, we're not doing the drip. That's fine, as long as we're not doing it for a reason. Heparin could also be contraindicated. There are certain situations you don't give heparin. But the third situation is we may just have forgot. And that's really why I want to get you guys involved, because, you could help remind us about a critical intervention that we may be forgetting or somehow accidentally got disconnected. So, Always think about heparin. So the next letter in Thanks Mom is A, T-H-A. A stands for aspirin. We all know aspirin. We love aspirin. Aspirin, to be honest, is probably the single most important thing, other than a 12 lead, that you do for your patients. When you give aspirin during a cardiac event, it reduces overall mortality by almost a quarter. That effect is actually bigger than TPA. So it's a hugely important drug. Just because it's like over the counter and costs 4 cents doesn't mean that it doesn't make a huge difference. Aspirin is absolutely critical for every patient, and there's no reason a patient should not get aspirin unless you suspect significant bleeding or they have an allergy. But we absolutely want to give aspirin to all of our chest pain patients unless there's a clear contraindication. So the next letter in thanks is N, N standing for nitrates. Nitrates, again, a drug that nitroglycerin, a drug that we're very comfortable with. It works in many different ways. One being that we believe it's a coronary dilator, thus improving blood flow and may help with collateral blood flow around an area of infarct. It also lowers blood pressure, which means the heart does not have to pump as hard against as much arterial resistance. And so that, in theory, reduces oxygen demand, which is good for a heart that's already not getting enough to a certain area of muscle. Contraindications, again, always worth reviewing. Any of your erectile dysfunction drugs, what we call phosphodiesterase inhibitors, Viagra, Cialis, I think Levitra is one of the other ones. If these have been given, and please review the chest pain protocol because there are different time frames for these. Some of the shorter acting ones like Viagra, you only have to worry about for 24 hours. The longer acting ones can be up to 72. But giving nitro in patients who are on those medications can cause a very huge drop in blood pressure. This is another reason if you're giving nitro, you have to have a line, you have to have fluids ready to go in case you do run into trouble. Right-sided ST elevation MI is also the other situation in which giving nitro can really drop your blood pressure. And so we always recommend, again, having an IV, having fluids ready to bolus. And we're going to talk about identifying a right-sided MI in a little bit. So the K in thanks stands for potassium. K is the abbreviation for potassium. And basically we use this to think about all electrolytes, but the big ones in cardiac care are potassium and magnesium. Now, I know you don't check electrolytes. We don't do iStats or epochs in the back of the ambulance. So you won't know what their potassium or magnesium is, but you can do what we do, which is the quick and dirty check, which is look at their EKG. And what you're primarily looking for is a wide QRS. Anytime you have a QRS that's wider than about 4 to 5 small boxes, you have to start thinking metabolic abnormalities like electrolytes or toxins, TCA, antidepressants being probably the most common, or at least the classic case that we talk about. The other thing you want to look for is a long QT. Which can also be an indicator of early potassium or magnesium abnormalities. And so this K is really to remind you to take a good look at the 12 lead and make sure that you're not missing some metabolic toxic process going on. So, if you look at this 12 lead, for example, particularly in lead 1, lead 2, if you look closely, you can pretty much convince yourself the QRS is pretty wide. It's certainly about 1 big box or 5 small boxes. And so, again, whenever you start seeing 4 to 5 boxes wide, QRS 4 to 5 boxes wide, you want to start thinking abnormality of potassium, magnesium, or tricyclic. And in fact, this case was hyperkalemia. And it was hyperkalemia mimicking STEMI. The crew thought this was a STEMI. Particularly, they looked at V1, and they called that ST elevation. They looked at V3. They thought that was ST elevation, even though that's really the QRS that's wide. And this person's 12 lead normalized after giving 3 amps of bicarb. And so Hyperkalemia is a STEMI mimicker, and we're going to talk about that a little bit more, but that's why the K is in this chest pain bundle. That's the K is to make you really look at your intervals and just double check and ask yourself, am I missing something metabolic, something toxic? So S stands for stress reduction. And we underestimate the importance of this. Stress and reducing stress is key when someone is having a cardiac event. So how do you do this? Well, one is be professional, have a great bedside manner, be reassuring. Another way we can do this that we don't use a lot, but we really probably should be using more is benzos. So benzos are probably a lot safer for pain and anxiety control than many of the medications we give. So benzos are beneficial because they do reduce sympathetic tone, which makes it less, that adrenaline surge that people get. By reducing that, you make people less prone to arrhythmia. You reduce the workload on the heart. Benzos are actually very good for non-cardiac chest pain. So people with esophageal spasms, people with musculoskeletal causes of chest or back pain tend to respond well to benzos. And then, of course, for chest pain that's specifically induced by cocaine, benzos are really the drug of choice. Now, I know you can't give benzos on standing protocol for chest pain, but I would like you to consider them. And especially, you're going to see why in a second when we talk about morphine and some of the downsides of giving morphine or fentanyl. I think this is really the direction we're heading in terms of AHA algorithms, that we may start relying more and more on benzos. Obviously, it would be a med control option, but one worth always keeping in the back of your mind. So that's thanks, THANKS. So the second part of that is MOM, M-O-M. And the reason MOM is a separate word is because the things in the MOM part of the chest pain bundle are things that are actually more controversial. So MOM stands for morphine, oxygen, and metoprolol. So let's start with morphine. So morphine is still the standard of care for chest pain. It's still in the North Carolina algorithm, along with fentanyl, but there is a move away from morphine, which is one of the reasons we're talking more about benzos. So one of the reasons people are shying away from morphine is it just doesn't work that well for chest pain, to be honest, especially in the doses we give it. We often give like 2 milligrams, which is pretty low dose. There's also some research that shows that morphine may worsen outcomes in people having large cardiac events, especially large STEMIs. And there are probably 2 ways that this works. One is that morphine may directly have a negative impact on cardiac function. And when someone has a highly compromised heart muscle to begin with, that may not be a good idea. But what's even more compelling, and this research has come out in just the last few years, is that morphine, and unfortunately other opiates too, including fentanyl, interfere with the effect of some of the most powerful anticoagulation medications that we give, particularly Plavix, which is a mainstay of treatment for someone who is having a STEMI or NSTEMI. And this is really interesting. There's a study that shows, for example, that if you give patients Plavix, they do much better than if you don't give them Plavix. But if you give them Plavix and morphine, those patients don't do as well as patients who just got Plavix. And at least in sort of laboratory studies, people have been able to directly show that morphine does affect Plavix function. So it's still standard of care. We still give it. But just understand that in the next couple years, as the AHA algorithms evolve, you may see morphine recommended less and less. And also, if you give a single dose of morphine and the patient doesn't seem to respond, think benzos, think med control, and seeing if they might consider a little bit of benzo. The second letter in MOM, oxygen, or O, stands for oxygen. And we've always given oxygen, right? We all have 2 liters nasal cannula for just about any medical problem that's going on. The problem is that it doesn't really do anything. And it may even do something bad. So, the idea is that, if someone's not getting enough oxygen, whether they're septic, whether they're ischemic, whether it's a stroke or an MI, the idea that if you give oxygen and you sort of supersaturate the blood, that can only be a good thing. Well, it doesn't really work. The other thing is that it may sort of confuse the arteries. So what I mean by that is, when you have an ischemic area of tissue, whether it's your heart or somewhere else in your body, there are chemicals that are released that tell the blood vessels in that area to dilate, to try to increase blood flow. If an area is getting too much oxygen, the reverse process is true. And so there's this self-regulation that occurs. So if you have an area of infarct in your heart, it's going to be signaling to dilate blood vessels in that area. But if you have highly saturated blood or blood that's highly saturated with oxygen, this oxygen tension may confuse the arteries and actually work against you. Again, it's something that's been shown in the lab. There are some studies that suggest at a minimum, oxygen does not improve outcomes. They're kind of equivocal as to whether or not the outcomes are actually worse. But you'll notice it's no longer in the North Carolina EMS protocol. So unless someone needs the oxygen, they don't need it. Unless someone's actually hypoxic with a SAT below 92, 94%, or unless they're on it permanently, there's really no need to give it to patients who are having active chest pain. So the last M in MOM is metoprolol. So we know that beta blockers are one of the best medications for long-term outcome in people with MI. Giving people beta blockers for at least a couple years after their infarct dramatically reduces death and reduces arrhythmia. We think that's because it reduces sympathetic tone, which reduces arrhythmia and overall mortality. So because beta blockers have been so helpful and have really made a difference in long-term outcomes, the idea was that, well, the sooner you get that beta blocker on board, the better it must be. And in the early 2000s, when I was working full-time in EMS, we were pushing a lot of beta blockers into the pre-hospital setting. What we're finding is that in both the pre-hospital setting and the emergency department, it probably doesn't help at all, that there's probably no benefit to getting it started any sooner as long as you get it started by the 24-hour mark. In fact, there are some studies that show that for big infarcts, beta blockers may slightly worsen outcome. And so you've seen a real turnaround in terms of trying to get EMS to push beta blockers. And we certainly are not using them anymore in the emergency department. It used to be that if I tried to admit a patient with chest pain and I had not given a beta blocker, I would get a lot of pushback from the physician, the cardiologist who would be taking that patient. Now there's no pushback. Now most people are waiting 24 hours to see how big the infarct is, to see if they develop cardiogenic shock, and then only giving beta blockers after that. So that's the chest pain bundle. Thanks, Mom. And I really want you guys to think about that every time you have a patient with chest pain. Am I doing the 12 lead? If I'm doing a transfer, does this patient need heparin? If they're not on it, why not? Have I given aspirin? Have I given nitro? Did I check the intervals looking for K, potassium, magnesium abnormalities? Am I doing everything I can to reduce stress for this patient? Do I need to think about a benzo? Maybe. And then the last three interventions, which we still do at least one of them, morphine, but you should really, be cautious about. So giving morphine for the pain, not giving oxygen unless they actually need it. And again, we're not giving beta blockers, but just understanding why we don't do that anymore. So that's the chest pain bundle. Thanks, Mom. So I'd like to focus a little bit on 12 lead, just some review. So, take a moment to look at this 12 lead and go ahead and pause the presentation. And basically, I'm asking you to identify what you think is wrong. So in this 12 lead, there's obviously ST elevation, and we usually look for the highest ST elevation when we say where we think the infarct is. So, to me, it looks like it's probably peaking around V3. So that is what we would call sort of anterior lateral, the anterior leads being V1, V2, and then you start to get kind of lateral as you get into V3, V4. You can see there's some likely reciprocal ST depression in the inferior in leads 3 and AVF. You can see there's ST elevation though pretty much all the way throughout the precordial leads, going all the way over into V6 and then into 1 and AVL. But again, we usually categorize this based on where we see the highest ST elevation, and so that seems anterior lateral. So we would call that most likely an anterior lateral ST elevation MI. So go ahead and take a look at this one. And again, pause it if you need to. So here, the ST elevation is a little more subtle. If you look at V1, V2, V3, V4, the precordial leads look all pretty good until you get over to lead 1 and AVL. And they're particularly in the first QRS complex of lead 1, as well as definitely in AVL, you can see some pretty convincing ST elevation. Again, there seem to be some reciprocal changes in the inferior leads, particularly 3 and AVF. And so this is what we would call, a lateral, and most people would call this a high lateral ST elevation MI. Usually we call leads 2 and AVL the high lateral leads. Let's go ahead and take a look at this one. Again, pausing if you need to. So here the ST elevation you can see in 2, 3 AVF. Not really a whole lot elsewhere. You see maybe the beginnings of depression. It's about 1 box in AVL. If you look at lead 1 and especially AVL, that's probably some reciprocal depression. But really what jumps out on this is 2, 3 AVF. And so we would call this an inferior MI because 2, 3 AVF are the inferior leads. And then we'll go ahead and have you look at this one. Take a moment, pause if you need. So this one's actually pretty similar to the last one in that you look for the ST elevation and it's pretty clearly 2, 3 AVF. You see some reciprocal again in AVL, so you would say inferior. But what I want to point out on this is that you can see reciprocal depressions, particularly in V1 and V2. And that is particularly important because when you see that pattern, elevation in the inferior 2, 3 AVF with depressions in V1, V2, that is concerning for a right-sided MI. It's not guaranteed, but it's pretty likely. And in particular, it's the depression in V1, V2 that should alert you to that possibility. The reason that matters is right-sided MIs are very sensitive to drops in preload. And so giving nitrates in particular can cause these people to bottom out their blood pressure. These are the patients who you may actually have to bolus. And I was actually going to have you answer that question on your own, but since we're not doing this live and it's recorded, in response to this 12 lead, the question is, would you divert away from Granville? Would you give aspirin? Would you give nitro? So, it's a STEMI, so we're definitely diverting. Aspirin, always, unless there's a really compelling contraindication. But as I said, this is probably a right-sided MI, and you might want to be hesitant to give nitro, or at least, also be bolusing some fluid or ready to bolus if you're going to try it. And that pattern in V1, V2 is what I was always taught was the carousel horse pattern. I don't know if anyone else has been taught this, but the reason you call it a carousel horse pattern is because if you look at V1, V2, you can kind of convince yourself there's a carousel horse there. Mainly the point of this is that the saddle, the horse's back, is below the isoelectric line. So what you're doing is you're seeing this tall QRS, which is like the pole, and then this depressed area where the saddle is. And that ST depression in V1, V2, when combined with elevation in 2, 3 AVF, should make you at least think right-sided MI. So these are the areas, the anatomic areas that we talk about. V1, sometimes V2 are considered septal. 2 and 3 are anterior. You start getting into 3, 4, 5. You're starting to get lateral. Lateral continues through V5, V6, and 1 in AVL. And again, people often call 1 in AVL the high lateral area. And then you have your inferior leads, 2, 3, and AVF. And so, again, you're looking for the area that has the highest ST elevation. And wherever you think you see that peak, whichever lead that happens to be, is usually how you name that anatomically. Doesn't really change your treatment unless, of course, you're suspecting a right-sided MI. But, just so that we're all on the same page, and you hear someone say septal MI or anterior MI, that's how you make that call. So similar to the previous EKGs, again, pause if you need to. So many crews would interpret this, many physicians would interpret this, at least at first glance, as a STEMI. And in fact, the computer obviously thinks it's a STEMI because it says acute MI STEMI at the top. Again, thinking back to Thanks Mom, the K, remember the K stands for potassium and magnesium. Always check your intervals, your QRS, your QT length. If you look closely, the QRS is quite wide, and there are many areas, V1, 3, AVF, where you can see that the QRS is at least 4 to 5 small boxes wide. And so you really have to start thinking, not a bundle branch with ST elevation, but maybe something else going on, toxic ingestion, or electrolyte abnormality. And in fact, this was a dialysis patient who had missed dialysis, and when they were given 2 amps of bicarb, their EKG looked like this. And so again, hyperkalemia, we talked about it before, is considered one of the great mimickers of ST elevation MI. First glance, someone throws this in front of me, especially with the computer read on top, I'm going to go into STEMI mode. But that's why you always take a moment, check your intervals. Another giveaway on this is, even though the computer says the ventricular rate's 100, it's obviously the computer's confused. If you actually count those QRSs, there's only about 8 on the page. The patient's real heart rate is actually about 48. And again, oftentimes with hyperkalemia or a tricyclic or some type of sodium channel blocker overdose, where you start getting that very wide QRS, you usually also get bradycardia. So that would be another suggestion that this is probably hyper K or something that could benefit from bicarb. And in fact, it benefits greatly. Let's say you're wrong, though. Let's say it's borderline and you decide to push bicarb, and it really is just a left bundle branch block with a STEMI. You're probably not going to do a lot of downside to pushing an amp or two of bicarb. And if you see no EKG changes with an amp or two of bicarb, then it probably is not a metabolic issue or a toxin issue. But there's usually not a lot of downside. Again, you can always fax the EKG to med control as well. So take a look at this EKG. Pause it if you need to. So this EKG is actually pericarditis, although to be honest, I'd probably prefer that you call it a STEMI and err on the side of a STEMI. Certainly in the ER, I'm going to err on the side of a STEMI and be talking to Duke about transferring this patient, unless they have an incredibly good story as to why they have pericarditis. But pericarditis is also a great mimicker of STEMI because you do get what appears to be ST elevations. And the one thing about this is you can see it in almost every lead, right? 2, 1, AVL, V1, V2, V3, V4, V5, 6. You can convince yourself it's global. And that's one giveaway. An ST elevation MI should not be elevated in every lead, but pericarditis often has ST elevation in every lead. It also tends to have PR depression, and if you look closely, you can see that the PR interval in a lot of these leads is below the isoelectric line. that's much more subtle to catch. And again, if you're going to err, I would divert this patient, to be honest, to Duke. But ultimately, this actually was a young patient who had just had about a week or two of a pretty severe upper respiratory infection, and was having chest pain, particularly that was worse with position changes, and was ultimately found to have pericarditis and a little bit of a pericardial effusion. Nothing significant enough to cause tamponade, but effusions are very common in these patients. So, again, pause if you need. So this is at least the left bundle. The QRS is greater than 0.8. When you look, obviously the QRS forces are big, particularly in V1, V2, V3, that QRS is very deep. On the flip side of that, you're getting those sort of tall peaked T waves. Now, historically, people have said, well, you can't interpret an MI through a left bundle. And there is some truth to that, but we're going to talk a little bit more sort of about subtle things that you can look for when you have a left bundle like this to try to figure out if there's actually a STEMI or not. So before we move on, take a look at this. And just kind of keep your best guess in the back of your mind. We'll take a look at this. Now this rhythm is paced, and for all intents and purposes, paced rhythms, ventricular paced rhythms are like bundle branch blocks, right? You generally get wide QRS. So the question is, can you make anything of these? So I want to spend a few moments talking about paced or bundle branch blocks, so these sort of wide QRSs. So one of the things that you get when you have a left bundle is you get what's called a discordant T wave, an ST segment. So what that means is that whatever direction the QRS is going, meaning above the line, the isoelectric line, or below the isoelectric line, the T wave should be the opposite direction. So this is a pretty standard left bundle pattern. And when you look at this, you look at lead 1, for example, the QRS is high, right? And the T wave points the opposite direction. It's discordant opposite direction. You look at 3, the QRS is down, the T wave is up. You look at V3, the QRS is obviously down, the T wave is up. And, take a moment if you need to convince yourself, but I promise you every lead works out that way. And that is what you should see. When you don't see that, things get a little tricky and you may have something going on. So this is what we talk about with Scarbosa's criteria. And there are a couple different criteria, but the one that I really want to talk about today is when you have concordance, meaning that the ST segment is on the same side as the QRS. So if you look at the lower left there, that ST segment is elevated in the same direction as the QRS complex. That should not occur in a normal left bundle or paced ventricular beat. So that's a giveaway that even despite having a left bundle, you may be seeing some ST elevation. Likewise, if the QRS is below the line, and the ST segment is also below the line, that's what we call concordant. It should not be in the same direction, but it is. And so again, that might be ST depression. So with that in mind, if we look back at some of these, here, if you look at V3, for example, the QRS is clearly pointing down, right? So that means that the T wave should be up, which it is, but it also means that the ST segment should at least be isoelectric or up. it should be above the line, but actually you see a slightly low ST segment there. It's depressed in the same direction as the QRS. V2, you can kind of see the same thing. V4 is a little more subtle. V5, it's kind of hard to tell. That QRS is kind of half up, half down, so it's hard to say. But, particularly looking at V2, V3, the fact that it's depressed in the same direction as the down QRS is concerning. And in fact, this was a STEMI. They went to cath lab, they had a full obstruction. So same thing here. This is another example. Take a moment if you need it. Pause if you need to. So what I want to draw your attention to here is particularly V4, V5. So in V4 and V5, clearly the QRS is up, right? It's pointed up. So the T wave should absolutely be pointed down, and the ST segment should be at least at 0 or below the isoelectric line. It should be on the same side as the T wave, which is always the opposite of the QRS. And here it's not. You can actually see the ST segment has elevated in the same direction as the QRS. And so this did end up being a lateral MI, sort of, centered around V4, V5. And you can also, if you look closely in 3AVF, you can convince yourself there's a little bit of reciprocal depression there. The QRS is pointed down in 3 and AVF, which means that the T wave should be up, which it is, but the ST segment should also be at least at 0 or above 0, and it's not. It's depressed in the same direction as the QRS. And so, these are subtle things, and I recommend taking some time Googling Scarbosa criteria and just looking through sample 12 leads online, because this is sort of a tricky thing. It needs a little bit of practice. But, I point this out because there are absolutely situations in which you can read ST elevation or depression through a left bundle. There are actually 3 Scarbosa criteria. We did not talk about criteria C. I will talk about that in a different lecture. I really just want to familiarize you with A and B, which is this idea that ST segments and QRSs should always be discordant, in opposite directions, never in the same side. Never both up or never both down. Both up being criteria A, both down being criteria B. Whenever you see that, highly suspicious for ischemia. So that's the end of our chest pain bundle. Again, I would like you guys to stop using Mona and start thinking, thanks, Mom, and using that every time you've got a chest pain patient in front of you. Also, don't forget about those critical non-ACS causes of chest pain, always having an index of suspicion for when those might occur. And if you really think you have one, contacting med control early, both to discuss what may be contraindicated in terms of medication, but also discussing possible diversion, as some of those are probably better served by diverting to Duke. So as always, feel free to call me or email Alan if you have any questions. Otherwise, I look forward to next month.